Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be covering secondary adrenal insufficiency. There are three causes of adrenal insufficiency: primary, secondary, and tertiary. And these are going to be important for you guys to be able to distinguish between while answering questions on step one. And all of these types of adrenal insufficiency occur at a different level in this pathway over here. So remember, our pathway for controlling the release of cortisol is our hypothalamus in our brain is going to release CRH, which will travel to our anterior pituitary, which will release ACTH. ACTH will travel to our adrenal cortex and stimulate those adrenal glands to produce hormones such as cortisol or our mineralic corticoids such as aldosterone, androgens, etc. And as we talked about in the previous video, primary adrenal insufficiency occurs at the level of the adrenal cortex. There's something wrong with the adrenal glands themselves. Secondary adrenal insufficiency, however, is going to occur at the next level. This is a problem with your anterior pituitary. Remember, your posterior pituitary is responsible for secreting ADH and oxytocin, but your anterior pituitary is what is going to secrete ACTH as well as all the other hormones the pituitary is responsible for making. Because in this pathway we are going to have a problem with our anterior pituitary is not going to be producing as much ACTH. Our ACTH levels are going to be lower. That's going to be an important distinguishing factor from primary adrenal insufficiency. And because these ACTH levels are lower, there's going to be less stimulation of our adrenal cortex, leading to decreased adrenal cortex activity and then decreased production of some of those important hormones, like cortisol. There are several different things that can cause this decrease in function of the anterior pituitary, and I like to think of these different causes of damage to the anterior pituitary broken up into three categories. First, we have mechanical damage. There's mechanical damage to the pituitary itself through brain trauma, brain surgery, etc. And then there's damage to the blood vessels that supply flow to our pituitary. So this can result from things like stroke or pituitary ischemia if you're not getting enough blood supply to the pituitary. A very specific type is known as K.A.N. syndrome. This occurs during labor, so if you have a postpartum hemorrhage, the anterior pituitary is very vulnerable to ischemia at that time because it has grown through pregnancy. It has been making more and more prolactin, so it has been replicating those cells and it is larger and more vulnerable to ischemic injury. So if you do have a large postpartum hemorrhage, this can certainly damage the anterior pituitary. Our second cause of damage to the anterior pituitary are infections, so tuberculosis or syphilis. And then finally, infiltrative causes of damage to the anterior pituitary. So you can have sarcoidosis or hemochromatosis, both of these diseases that will cause buildup of other substances within the pituitary that can damage it and lead to secondary adrenal insufficiency. As we already mentioned, in secondary adrenal insufficiency, unlike primary, we are going to have decreased levels of ACTH because our anterior pituitary that produces ACTH is what is damaged. Because we have decreased levels of ACTH, then we are going to also see decreased levels of melanocyte stimulating hormone that is encoded on the POMC gene. And because we have decreased levels of MSH rather than increased levels, we are not going to see any hyperpigmentation. So you'll notice that JFK was not included on this slide because there's no hyperpigmentation seen with secondary adrenal insufficiency, and that is going to be a great way for you to be able to distinguish between the two. If you see hyperpigmentation in a question stem, it's a good bet they're talking about primary adrenal insufficiency rather than secondary. And then finally, aldosterone synthesis is going to be unaffected in secondary adrenal insufficiency. That is because aldosterone is not as tightly regulated by ACTH, and so its synthesis is not going to be affected when we have damage to the anterior pituitary. The classic presentation of secondary adrenal insufficiency is going to relate to the hormone that is most decreased, which are your glucocorticoids. Cortisol, most famously, the decrease in cortisol is going to lead to weakness, fatigue, orthostatic hypotension, muscle aches, hypoglycemia, weight loss, GI symptoms. Remember, cortisol is responsible for maintaining blood pressure, also for maintaining appropriate glucose levels in the bloodstream. So when we have decreased levels of cortisol, that is why we will see this orthostatic hypotension, hypoglycemia, and all of these symptoms that are related to decreased energy, like fatigue and weakness. Additionally, we will have symptoms of decreased androgens. So because androgens are important for maintaining mood, concentration, focus, energy, and are important for the reproductive systems in both males and females, without these androgens, you are going to have depressed mood, decreased energy, decreased concentration, and then in females, lower androgen levels can lead to irregular menses, as well as erectile dysfunction in males. So decreased cortisol and decreased androgens are going to be responsible for most of the presentation symptoms in secondary adrenal insufficiency, but I want to reiterate that we are not going to have any symptoms associated with decreased mineralic corticoids because our aldosterone levels are normal. And then similarly, we are not going to have any skin hyperpigmentation. This is a really key point because our ACTH levels are decreased rather than increased like we would see in primary. This leads into important diagnostics here. here. Decreased ACTH, again, that is going to be a difference from primary adrenal insufficiency. Decreased cortisol, this is going to be pretty constant for every type of adrenal insufficiency we talk about. Normal aldosterone levels, that will also distinguish from primary adrenal insufficiency, as well as normal potassium. And this normal potassium is, of course, because our aldosterone is functioning normally, our RAS system is intact, whereas in primary adrenal insufficiency, we might see elevated levels of potassium because we have decreased levels of aldosterone and that sodium-potassium pump isn't functioning as well in the kidneys. So this is going to be another key differentiating factor between primary and secondary adrenal insufficiency. Our morning cortisol levels are going to be low. Our morning ACTH levels will also be low given the decreased ADH with secondary adrenal insufficiency. And then ACTH stimulation test, we're actually going to see increased cortisol. Now, why would that be? Well, the problem in this pathway, unlike in primary adrenal insufficiency, where we had a problem with the function of the adrenal cortex, is actually a problem with the anterior pituitary. So the anterior pituitary is not sending as many signals to the adrenal cortex to produce these hormones, but the adrenal cortex is still quite functional. So when we provide the signal to the adrenal cortex that it should be making these hormones in the form of exogenous ACTH, the adrenal cortex is still able to function and create these hormones, and that is why we will see a response to the ACTH stimulation test in the form of increased cortisol. Again, that is a great way to distinguish from primary adrenal insufficiency where we would not see a response. And then the management of this deficiency is, again, just to give what the person is lacking. In this case, it would be glucocorticoid replacement. So to quickly recap what we talked about in this video, secondary adrenal insufficiency is going to occur at the level of the anterior pituitary. It's going to result from anything that can damage the pituitary, like mechanical damage, ischemic damage, infectious damage, or infiltrative damage. And then you can distinguish secondary adrenal insufficiency from primary adrenal insufficiency, first because there will be normal aldosterone in secondary adrenal insufficiency as well as normal potassium. Aldosterone will be decreased in primary and potassium will be elevated in primary, but both are normal in secondary adrenal insufficiency. Additionally, you will have decreased ACTH. This is probably the most important diagnostic test for you to be able to differentiate secondary from primary, as well as the response to the ACTH stimulation test, which is increased cortisol in secondary adrenal insufficiency, but no change in primary adrenal insufficiency. Now, how'd they ask you about this on a board style question? Well, something they might ask you is a 32-year-old woman, G1, P1, is 3 weeks status post-vaginal delivery of a healthy male infant. Delivery was complicated by an estimated 1,700 milliliters of blood loss. The patient has recovered well, but reports continued weakness, depressed mood, and decreased energy. Morning cortisol and ACTH levels are both below the normal range. What is the embryological origin of the organ responsible for this patient's decreased ACTH? Okay, so we have a woman who lost 1,700 mLs of blood during her delivery. That is certainly criteria for postpartum hemorrhage, which places her at risk for K.A.N. syndrome. She's presenting with decreased energy, fatigue, depressed mood, all these things that could be signs of postpartum depression. She's 3 weeks out, not 2 weeks out, so it would be depression rather than blues. But given her abnormal cortisol and ACTH findings, this is more likely an adrenal insufficiency picture rather than a psychiatric picture. And given that we have decreased ACTH in the setting of a plausible cause of damage to the anterior pituitary, this is going to make me highly suspicious for secondary adrenal insufficiency from K.A.N. syndrome. The question then asks us, what is the embryological origin of the organ responsible for this patient's decreased ACTH? Well, the organ responsible for decreased ACTH is the anterior pituitary. The anterior pituitary is what's damaged in secondary adrenal insufficiency. And if you remember back to our embryology videos on the anterior pituitary results from Rathke's pouch and outpouching of that oral ectoderm, where it is our posterior pituitary that is pouching out from that neural ectoderm posteriorly. So for this question, because we're asking about the anterior pituitary, your answer would be the oral ectoderm or Rathke's pouch. Now that's all I have for you on secondary adrenal insufficiency. I hope this video was helpful, and I'll see you next time.